Right, well, just a heads up that we actually will be hosting an event on climate finance and how we are going to fill that financing gap as we look ahead to COP29 during London Climate Action Week on June 25th in London. And we also will be looking at the intersection with health. So if you'll be in London that week, please join us. So I'm very excited to welcome back to the stage Sara Jerving to lead our final session on combating AMR.
Thanks so much, Kate. If I could be joined on stage by our speakers, please. So we have Caroline Boulton, who's Global Program Head of Novartis. Dr. Otto Cars, who is Professor Emeritus at the Infectious Diseases, thank you, founder, and founder of React Action on Antibiotic Resistance at Uppsala University. Dr. Lucica Ditiu, who is Executive Director of Stop TB Partnership, and Jeremy Knox, who is Head of Policy of Infectious Diseases at Wellcome. Thank you all for joining us. So antimicrobial resistance is considered a silent pandemic because it's a huge issue, but it's not getting enough attention globally. But it threatens to turn back the clock on a lot of advancements made in modern medicine, creating a situation where common infections could become untreatable and common procedures would become unsafe. I'm hoping, Dr. Cars, if you could please expand upon that, on the dangers of AMR and why pharmaceutical companies are not developing new antibiotics.
Thank you very much for the invitation here. That was really two questions. I actually tried to be quick. I mean, we are facing a situation where humans are outpaced by bacterial ingenuity. And bacteria are experts in behavioral change. We are not. So that's part of the problem. We know now that 1.2 million people die every year because the drugs, the antibiotics that are given. I will talk about bacterial diseases. We will talk about malaria and tuberculosis a bit later. So we know the burden is enormous. 1/5 of these are children, and most of the burden is in South Asia and Africa. Having said that, we also need to see that antibiotics is also challenging the health systems as such. All health systems in the world, even the weakest, are completely dependent on access to antibiotics to work. And what happens if it doesn't? The system will crumble. And we see the challenges, as you mentioned. Modern medicine is at stake now, for sure. We are talking about ethical considerations to treat patients with harboring multi-resistant bacteria in their gut flora with cancer because the risk of dying of sepsis is too high. Children, specifically the preborn children, are really at stake with sepsis. A major surgery and a transplant cannot be done safely without antibiotics. So we have not really understood and come to grips with the magnitude and dimensions of the problem yet. And that leads us to the second question, because why have we reacted too slow and also too narrow and too weak? Well, I think one answer to that question is not the answer, but one answer is that we have been relying for too long for the pharmaceutical industry to deliver new antibiotics when the old ones have been worn out, so to say, and stopped working. And that is obviously still the case for many. So I think we need to change that. And the question was, why are the big pharma leaving? Well, most people would think that that's an economic reason. Their profitability is lower than for good diseases, for chronic diseases and so forth. And that's absolutely true. That's one factor. But in fact, my belief, and I think I share that with many experts, is that the real challenges are the scientific bottlenecks, the barriers, to get a new antibiotic inside a bacterium with all the complexity of its shell and different layers and whatever properties you have to have. And that is not fixed yet. So I think, and one example is a recent example, a review article when they studied 48,000 potential molecules that could become an antibiotic. Out of them, 0 entered further development. So we have a major problem there to start with. So that was, and the solutions will come later in the discussion. But obviously, the public sector need to take a much stronger responsibility for the whole issue, including for development of the medicines we need.
Turning To Jeremy, if you could talk a bit about kind of research ecosystems and what a Wellcome Trust is doing to create those to combat AMR.
Yeah, of course. So Wellcome as an organisation, as a research funder, we've been very heavily engaged in AMR for really a decade or so now, and I think really trying to think about how we can mobilise our resources and mobilise our capacity and capability as a funder to make the greatest inroads. We're doing that in a few ways. So, for example, we spend a lot of effort trying to improve understanding of the AMR problem, trying to build evidence for action. So, for instance, we were a major funder of something called the GRAM study, which has given us kind of the understanding, the data on the burden of AMR that Otto described, and is starting to give us real country-level understanding of where the greatest burden lies, what are the key bacteria we need to be targeting. And addressing things like the antibiotic R&D ecosystem, this is one where we've really tried to take that ecosystem approach of thinking from end to end, all of these problems, all of these failures that are meaning we don't have the pipeline of products we need, how can we address that? So what does that mean in practice? For example, in early stage research, we were a founding funder of Carbex back in 2016, which is supporting a growing portfolio of drugs, diagnostics, and vaccines. We've been looking at the later stage problems, so a cliff edge as products mature through clinical trials and facing real shortfalls in funding. And we support something called the AMR Action Fund to support later stage clinical trials, but then also trying to think about other things as well. So for instance, how can we make clinical trials more efficient? So supporting clinical trial networks for antibiotics to make sure that trials can be done more quickly and more cheaply. And then finally, and kind of where I come in, is the policy side of things and thinking about the end market. Why is it that we have this market failure, these barriers to access and uptake, and what are the calls we can place on policymakers in terms of market shaping mechanisms, new ways to create incentives? So it's that type of end-to-end approach that we try and bring to a problem as complex as AMR.
And Caroline, your company is working on combating parasitic resistance to malaria treatments. Can you talk a bit about the problem and then what your company is doing?
Yeah, thanks. So most people don't actually realize that resistance that occurs as a response to parasites is part of this AMR topic, but actually it's a huge issue in malaria. We have a long history of drug treatments failing because the parasite can adapt so quickly. And if you think about the situation 20 years ago where the standard of care at the time, chloroquine, was used, actually there were probably millions of deaths because that drug failed. The standard of care that was introduced at that time was artemisinin in combination therapies, and now there's some evidence that those are starting to fail as well. So we're on a knife edge in terms of the way that we can manage malaria infections going forward. So actually, as the name implies, artemisinin in combination therapies, it's two drugs together. So you've got the fast-acting component, which is responsible for clearing the first malaria infection, and you've got a longer-acting partner drug. Now, all of the evidence suggests that there are resistance mutations out there to the short-acting drug, which means that the parasites are being cleared less quickly. And that puts all of the pressure on the partner drug. When the partner drug starts to fail, then we have treatment failure and we have patients potentially dying of malaria, which should not happen in this day and age. So what we need is new treatments, non-artemisinin treatments, which can reduce that risk of partner drug failure. And that's what we're working on as Novartis. We actually have a whole organization. We're still discovering new antimalarials, we're developing them, and we're trying to make sure that they get to the patients that need them. We actually have 3 programs in the clinic at the moment. We have 1 in phase 3, and actually we're developing these specifically to remove the threat of the resistance mutations taking hold in communities. And we're obviously also trying to make sure that they're easy to use by communities, because we know that poor adherence to therapy also results in resistance. So we're trying to fix the 2 things at the same time.
Turning to you, Dr. Lucica, so drug resistance tuberculosis is one of the deadliest forms of antimicrobial resistance. Why is that?
Yeah, so thank you. I just want to mark a good star for Devex and this kind of panels, because I'm tired of places in which people invited read a statement from a paper, and I'm really happy that we here speak free. So I actually actively push for a WHA without statements. So going back to the TB, to the question you had. So you see, tuberculosis is an airborne pandemic. Okay, I know that people are a bit worried to use these words because of political reason, but it is an airborne pandemic. And if there is something we are all at risk, is TB and its resistant forms, because we can take it in places very easy as long as we breathe. So the first reason, the first thing of why it's so important is that it's everywhere and nobody can protect themselves. I am infected with TB and I'm a bit worried, what if it's drug resistance, okay? The second thing is that in addition to that, the resistant forms, the ones that we hear a lot is the multi-drug resistance. You know, TB is treated with a cocktail of antibiotics. The ones that capture the attention are rifampicin and a few others that are creating the so-called MDR. But then we have the more complicated forms in which the bugs is resistant to almost everything, which is the extreme drug resistance. But we also have the monoresistant forms that are complicated, the treatment and the options that we have. So the other reason is that, unfortunately, we have according to WHO, around 25% of the world infected with TB. Okay, we don't know how many drug resistance, mono, whatever type of resistance. Leave it there. And then the other thing is that we have a large number of people that die with TB because of drug-resistant TB. According to WHO, that's 160,000 people a year. That puts a high proportion of it's actually in top 2 killers of the AMR if we take that figure of WHO, which looks at, so it's, what I'm trying to create here is the burden picture, okay? So, but and WHO recognized that by including TB in the critical pathogen list that was just issued, I think 10 days ago, so recognizing this problem. But the other problem that is actually very scary is, and you discussed already, is that we don't have too many, we have only few new drugs, the bedaquiline and the lamanid. We don't have any new options. If we lose bedaquiline because of the poor access, because of people interacting, before of, God knows, quality, before of bad management of people interact, we are doomed. Not me working for Stop TB. All of us, okay? Because the options of treating drug-resistant TB will be dramatically reduced. So I know we will speak about access and so on. So what we advocate for, I don't think the time in which, and I very much understand, support your point about malaria, the time of looking at this disease and their contribution to AMR separately, it's past. So we need to think all together how we can contribute and decrease the number of people suffering of AMR, whatever angle we look at. And there can be some smart ways of doing it by investing in smart tools that are not just for one disease, but for multi-diseases. And I can speak a bit later into that. But that's
Thank you. Thank you so much. Dr. Otto, there's been a very slow global response on AMR. What do you think can be done to change that? And I'd be interested in your perspective. I personally have seen more AMR conversations at this WHA than kind of the previous one. It seems like there's a little bit more traction in the global conversation. Would you agree, or are we a long way off?
No, absolutely. This is the year, but it's not the year. We need to go further. But of course, the high-level meeting that will come up in September has obviously been a very important lever. So many more stakeholders and groups are acting now. And there are a lot of commonalities across. I agree. But I have a long list here. Starting with behavior change, I think we need to, I mean, if we know more or less what we're talking about here in the panel and the expert groups and so forth, but you talk to people, they don't know anything about AMR. We simply need to change the language, the understanding of what we're talking about. Talk about diseases instead. And for me, the bacterial infections are key. They travel with us, within us, between animals and within the environment in the One Health perspective. So I think we need to include much more experts from behavior change, social sciences, anthropologists, and really make a case for changing behavior and awareness raising in all countries, context specific. This is a big tall order, but it needs to happen, because if people don't know why to go to an antibiotic, why stay away? We can't get anywhere. Behavior is key on that level. On R&D, I would call for nothing less than a global research institute across sectors on drugs, vaccines, and diagnostics. We simply need to do better. We are failing, and if we lose one, and you said that as well, we are out. So that's really another one. Then on the national governmental level, I think an easier win is to implement water and sanitation in all health care facilities, infection prevention and control. This can save hundreds of thousands of lives. You know that the Lancet series come out just now telling us that. We knew it before, but now we have the figures. And also on the national level, we need to make governments to collaborate. The issue is sitting mostly with the Ministry of Health, maybe sometimes with the Agriculture Minister and Environmental Minister, but not with the Finance Ministers. Why not? We need to build a case for a cross-governmental action on this, on these issues. And the same thing is on the global level. We have the quadripartite, the four important organizations within the UN system, but there are many more that should act. UNDP, UNESCO, others. We need to have a broad, UN cross-cutting collaborative mechanism for accountability. So it's a long list. I hope that this high-level meeting will trigger at least some of this to happen.
Thank you. And to bounce off of that, Jeremy, if you could talk about the significance of the UN high-level meeting and what you hope comes out of it.
Absolutely. So Otto, as Otto has alluded to that, really we're not going far enough or fast enough in the global response to AMR, and there's been a great deal of collaboration across the system. The quadripartite, I think, is much stronger than it was several years ago, but we're still at the point where we fundamentally need a step change, and we're trying to think about how we can use the UN to deliver the step change this year. And I don't disagree at all with the list of things that Otto described there as things that need to happen, but I think we need to be realistic that not all of those things will be solved in a single day, in a single political declaration in New York. So what I'd suggest is trying to think about this in terms of a framework of what are the things that the UN could actually deliver to really kind of change the structure, change the governance of the global response to AMR. And I'd say there's three things to that. Firstly, there's targets. We've lacked them so far in AMR. We've seen in other areas of global health and climate change, it's been really important to have very clear metrics of what success looks like and being able to keep track of progress towards those. It's a cliche, but what gets measured gets managed. And we've been lacking that so far in AMR, but we should be moving towards that now. There's I think a long list of things you could write targets, very kind of technical targets about for AMR, but the most important thing the UN can deliver is a political statement, a political commitment, something like 90-90-90 for HIV or 1.5 degrees in climate change that can kind of be the goal, the target that can unify efforts and really drive things forward. The second thing is an evidence panel. There's been lots of talk over the course of this week about this and the idea of having something like the IPCC for AMR to make sense of the growing pipeline of research we have out there and help guide governments, help prioritization of efforts, and help keep track of things like drug-resistant TB and drug-resistant malaria, which don't always feature as much as they should in the AMR conversation. And then finally, there's follow-up mechanisms and really making sure that once we've got the targets, once we've got the evidence base being used in a more systematic way, how can we make sure that we're really making progress against that? We need something more than just high-level meetings every 4 or 5 years at the UN. We need something more than just the World Health Assembly to keep track. We need regular moments every couple of years maybe to bring ministers together and really focus across multiple sectors on what progress is being made and review progress and guide prioritization going forward. So that's the kind of three things I think we could deliver from this year.
Now, turning back to access, Dr. Lucica, drug-resistant tuberculosis can be a very expensive treatment process for individuals, which reduces access. Your organization announced a price reduction last year for a critical TB drug. Can you talk about the importance of pricing of these drugs and kind of other barriers to access and how to turn that around?
Yes, and this links somehow to what was already said. So yeah, in Stop TB, we have a team called Global Drug Facility, and there was a lot of work with the private sector constituency of our board and so on. So there was a drop in this important component of the drug-resistant treatment of more than 50%. But the cost remains high. It was it remains high comparing with the normal TB, several times, 6-7 times at the best. And unfortunately, and this is not just a TB problem, I know it's malaria problem, is not that much of HIV problem. The funding is really, really, really limited, and we don't have the resources. And this is the drama when I hear about all the research and all the investments that we have. They will never deliver as far as they don't reach the people. So access is huge. And in TB, I'm for sure is not just for TB. The population that we work, the people with TB have the most vulnerabilities. And, they are not the easiest or the lover of the coverages of newspapers or magazines. I consider reaching the people with TB an indicator for reaching UHC, because they are having so many associated things. So what we do for access, and that's linking somehow with what you just said, both of you. What I think is needed in the AMR, and I agree completely with the point on behavioral change, that takes time, and it takes repeated messages to come. It needs a huge involvement of communities and civil society, and a huge demand. And we are pushing for this in terms of access as well. And what we can offer from Stop TB side, we have a funding mechanism in which we currently have 300 organizations, grassroots at national level, that we are funding as advocates and pushing forward the TB agenda. But it's not just the TB agenda, it's drug-resistant TB, and why not? They will be dying of resistant malaria or so. So what I'm offering is to really look and sit together. And actually our people went to the multi-stakeholder hearing in AMR, and because they were so vocal, they were the only one visible, because they have no shame, and we should have no shame. So I think what I want to say is that the access will not be sorted out without the involvement of people affected. And what I think will strengthen the discussion on AMR is engaging a huge number of civil society and advocates and communities, understanding the topic. I think somebody said about the language and what is said, and also embracing it. And I think with this, we can achieve much more. The last thing that I want to say is this. On the UNHLM, there are, and I know we are looking together with several colleagues from UK and others, and we have some key asks from the TB community for AMR, but there are things already negotiated and agreed last year, including targets for example, for TB, that are an easy win to be already there, because there was already a negotiating happening, so it's countries are going to be in a difficult position with all these negotiations. So already things that were approved, it's easier to push in there. So just a tip. Thank you. Thank you.
Thank you. Carolyn, so your Ghana Plus Lumefantrin combination drug is in phase 3 trials in a few African countries. What are you hoping to prove in these trials, and what's the timeline? When could communities potentially access this drug?
Thanks for the question. So this is ganaplacide lumefantrin, which is just going into phase 3. And I have to say, we partner very closely with the WANACAM2 consortium funded by EDCTP and Medicines for Malaria Venture, who help us to execute the trial successfully. But it started a couple of months ago. We actually are enrolling patients in Democratic Republic of Congo at the moment. But actually, because 95% of the burden of Plasmodium falciparum, that's the most virulent parasite that we have for malaria, that's in sub-Saharan Africa. So our trial is being conducted mainly in sub-Saharan Africa across 14 different countries, also in India, because they have a small burden as well. But actually, what we're trying to do is go quickly to the communities that actually are going to benefit from the drug, make sure we're studying against the appropriate target population. So also the majority of patients that get malaria are children. So actually our phase 3 trial has adults, has children down to 5 kilograms body weight. That's just under 6 months of age. And we think it's really important to study those patients who are the ones that are likely to need the drug in clinical practice early. So actually what we're trying to show is that we're looking at the effect of ganaplacide lumefantrin in adults and children with acute uncomplicated malaria. We're going into those areas where resistance mutations are occurring right now and where it's a problem. So we'll hopefully be able to demonstrate that actually the drug, the combination, is completely effective at clearing those resistance mutations and stops them spreading onward. We're actually going to be demonstrating the efficacy against the current gold standard therapy. And there's actually a WHO standard of 95% patients of cure rate at 28 days. So that's the target we're going for to demonstrate in the trials. But I think one of the interesting aspects of this phase 3 combination is that it actually, not only does it treat the infection, but it actually kills the sexual stages of the parasite. So hopefully it stops the infection being transmitted on through the mosquito. And we think that's a really important attribute, which is going to help curtail the onward infection. So we hope to complete the phase 3 study next year, and then obviously to go through the appropriate health authority approvals and get the drug out to communities as quickly as we can. But if there's a public health emergency in the meantime, because of the emergence of resistance, we're already thinking about how can we get the drug out to the communities that need it.
Wonderful. Well, we're unfortunately out of time, but thank you all so much for joining us.
Thank you.